Dr. Meghna has joined.
Hello, madam.
Hello, Meghna. Hi.
Good evening, Meghna madam.
Good evening, Meghna.
Good evening, Rajesh.
Hello, Dr. Meghna. Hi.
Hello.
Hi,
Hi, Dr. Parna. You changed?
Without the gown.
She's at work. She's at work.
She managed to change fast.
Yes.
No, this is my OT dress only.
Oh,
Yeah, it's
Without
okay.
the gown.
She always works. She always works.
Good evening, sir. Good evening, Parna.
Good
Ma'am.
evening, Vatkar madam.
Good evening. Good evening. Yeah. Hello. A nice topic today. Like, I am on vacation, so I can join in time. Yeah.
Good evening, ma'am.
आम्हाला समर वेकेशन सुरू झाली ना.
Correct, Balaji?
Yes.
Good evening, all. A special guest for today's lecture, Dr. Rakesh Garg sir and Dr. Meghna Nadkarni madam. Both are working in a onco-anesthesia field from last 25 years around, and we are very fortunate to have such a great speakers with us today. Today is the fourth webinar of SAMS, and I would like to request Dr. Balaji Asingavkar to brief on our webinar series on the recent anesthesia, recent advances in anesthesia.
Good evening to all. First of all, from SAMS, I welcome all of you for this recent advances series. And in our tenure, we started with this recent advances series. And first it was on cardiac anesthesia, then neuro anesthesia, and this time we are fortunate to have a great speaker like Rakesh Garg sir and Meghna Nadkarni madam, who are going to talk about recent advances in onco-anesthesia. As you know, Rakesh Garg is a chief editor of IJ, and since he has joined, he has changed IJ in such a way that it is much more readable, and its reach has been definitely increased many times. And he's a very humble, very nice person, and very good academician. And we all are eager to hear from him about the recent advances in onco-anesthesia. Now I hand over the proceedings to Dr. Rajesh.
Well, moderators today, as a moderators, Dr. Anita Neti ma'am and Dr. Balaji Asingavkar, our president, both are known to you. I think there is no special requirement or introduction of both the moderators. I would like to request first Dr. Vikas Karni to introduce our beloved president, Dr. Balaji Asingavkar. Dr. Vikas.
Good evening, everyone. Thank you, Dr. Rajesh. As you rightly said, Dr. Balaji sir does not require any introduction here. He's a dynamic and beloved president of SAMS, and with his leadership and thoughts, we have started this series of SAMS webinar, monthly webinars, which is focused on super specialty. And I'm sure today's fourth webinar of SAMS is going to be another super packed academic feast for all of us, with Dr. Rakesh Garg sir and Dr. Nadkarni madam with us, who both of them with their experience is going to enlighten us over onco-anesthesia. And we are fortunate to have Dr. Balaji Asingavkar as our moderator for this webinar. He is a well-known cardiac anesthetist from Aurangabad, and his contribution to MSCISA previously and now SAMS has been phenomenal. And I welcome him to moderate this session. Dr. Rajesh?
Our second moderator, yes, our second moderator, Dr. Anaesthesia Madam, President-elect SAMS. I would like to request Dr. Sachin Kandavkar to introduce Anaesthesia. Dr. Sachin.
Yes, sir. Yes. 1 minute. Sir. Good evening to all. I am audible?
Yes,
Yes.
Yes.
You are audible, Dr. Sachin.
Yes, yes, yes. Good evening, all. Today's our moderator, Dr. Anita Nate, ma'am. Good evening. She did an important post held at Anaesthesia Association, President-elect, Maharashtra SAMS, editor, Mission News, GC member, and President ISA Nashik, which was her past post. Present affiliations are consultant anesthesiologist, Vedant Hospital. Ma'am was invited as a faculty in various state and national conferences. Also, she is a reviewer of Indian Journal of Anaesthesia. She is also a certified trainer for Indian Resuscitation Council and pediatric perioperative life support. And ma'am did a very good charitable activities like working with Smile Train as an anesthesiologist since 2008 and active Rotarian since 2016.
Thank you, Sachin.
Thank you, sir.
After this brief introduction of moderators and about our webinar series, we will start our lecture from Dr. Rakesh Garg. Sir, I would like to request. I would like to request Dr. Sujata ma'am. Hello.
Sir, request Jenica person to mute all, only the host and we can be the same. Dr. Rajesh, sir, please unmute yourself.
Yes.
Yeah.
Dr. Sujata Jine ma'am will introduce Dr. Rakesh Garg.
Yeah, thank you, Dr. Rajesh, sir. Good evening, everyone. With permission of respected President, sir, and all respected office bearers of SAM, I take the privilege and task to introduce our dignified faculty for today's session. He is the man of virtue and simplicity with a broad vision to raise the flag of ISA and to more and more high. Sir has changed the scenario of Indian Journal of Anaesthesia and raised the bar by adding various infographics, smart use of QR code, IJA broadcast system, and innovation in itself. The most dignified faculty, Dr. Rakesh Garg, sir. I take the privilege to welcome you, sir, on behalf of Society of Anesthesiologists Maharashtra State Chapter. Dr. Rakesh Garg, sir, is a professor in Department of Onco-anesthesia and Palliative Medicine at All India Institute of Medical Science, New Delhi. Sir is a hardcore academician with more than 10 additional qualifications, including fellowship in palliative medicine, fellowship in clinical research methodology, and evidence-based medicine. Sir's special area of interest are onco-anesthesia, airway, research methodology, cancer pain, and palliative medicine. To his credential, there are more than 350 publications at international and national journal, authored 25 chapters in book, edited 2 textbooks. Sir has conducted more than 50 workshops on airway, mechanical ventilation, vascular access, and many more. Sir has big list of award-winning and achievements. A few to mention are ISA President Appreciation Award 3 times for significant contribution towards ISA and development of national module for CPR and research and publication. Singapore Medical Journal Reviewer Recognition Award, ISA Bhopal Award for Academic Excellence, and the list is endless. मराठीत म्हणतात ना, मूर्ती लहान पण कीर्ती महान. Please welcome Dr. Rakesh Garg, sir, our own Editor-in-Chief, IAJA and Journal of Onco-Anesthesiology and Perioperative Medicine. Today, with the theme of recent advances, Sir will talk on recent advances in onco-anesthesia. A warm welcome to you and over to you, Sir.
Thank you so much, ma'am. Thank you so much to the whole team of SAMS, including Dr. Balaji, Dr. Rajesh, and all their team who are doing wonderful work in taking the society forward and doing the wonderful work. And thank you for the kind words for introducing me. I think this is just a team approach, and I thank you, each one of you, for helping the ISA National as well as the Indian Journal of Anesthesia for all the work. I think credit goes to you all. So, coming to the topic for the day, so talking about the recent advances in onco-anesthesia, there have been so many things which have changed over time in onco-anesthesia, especially last 3 to 4 years. And many research are being done because it is an ever-emerging field. There are many challenges into it, and the solutions are coming through research and experiences. I'll be touching a few of them, being a very big topic, but I will take the pertinent aspects which are very, very important from the patient outcome point of view with regards to the onco-anesthesia. So when we talk about the onco-anesthesia, the management is a little different in these patients. And the reason are many. Why they are not equivalent to other type of surgical procedures? Because the perioperative care is hugely influenced by the impact of cancer per se. We very well know that cancer will have some systemic effect on the various physiology of the body. It will also have local effect of the cancer with regards to impact on the system which has been involved. Moreover, many of these patients would require pre-surgery various treatment, which may be in the form of chemotherapy, radiotherapy, or various interventions.
Sir, sorry to disturb you. Your screen is not visible. Did you share the screen?
Yeah, sure. I will check again.
Yeah, please.
Is it visible, ma'am?
No, sir. Anyone from Jenica, can you please guide? Yes, sir. Now we can see your screen, but
My audio is also okay, ma'am?
yes, sir. Audio is okay.
Yeah. Thank you so much. Sorry for the inconvenience.
Yeah, I'm sorry to interrupt you, sir. Please.
So when we talk about the recent advances in onco-anesthesia, these will have different impact. And the reason for different impact, as I just mentioned, is because of the impact of cancer per se, the impact of treatment, the impact of patient psychology. And we have very well understood that those patients who are psychologically differently behaved during the perioperative way, and this too happens in patient who has recently diagnosed with cancer, will have poorer outcome. Moreover, there is recent concerns about our technique and the involvement of these patients, whether the anesthetic management or the drugs that we use, is there any impact on the cancer recurrence? Because we are doing surgeries for cancer, and if our management itself leads to certain concerns, it will be a huge issue. And that's why it requires a lot of different techniques, different management, involvement of combination of various aspects. So the perioperative management of oncosurgeries are different because the impact of this cancer itself for treatment would require a different strategies. Moreover, we need to understand that we are not only looking for the therapeutic management, the role of anesthesiologists in cancer patients are multi-pronged. And the more lately, it will be the involvement of these patients in preventive and palliative aspects. And that again becomes very important because there are many, many concerns when we talk about these patients for palliative management. Now, if you see the recent advances in cancer surgeries, there are many, but primarily they are related to the anesthesia techniques, the analgesic techniques, the concerns of cancer recurrence, concerns related to the fluid blood management, use of ultrasound in the perioperative care, the monitoring tools which has come up, newer guidelines. There are many things, and we'll try to touch some of that. Now, this is an important aspect because when we talk about the preoperative optimization, we need some time. And this time, maybe, let's say, for example, if you're looking for optimization of the underlying disease, it may require a couple of days to weeks. But for cancer surgeries, we cannot wait for a very long time because there is always a risk of cancer locally advanced or being metastasized. So this is what the classification says, that these are time-sensitive surgeries. They are neither routine or elective, and neither they are urgent. So we have somewhere around 4 to 6 weeks wherein these patients can be optimized or assessed or prehabilitated. And this is what we have kept these cancer surgeries as time-sensitive surgeries. So this means when we say time-sensitive surgeries, we need to understand that there will be certain interventions, which could be preoperative chemotherapy and radiotherapy, which would require their side effects to settle down. So usually many of time these patients would be posted for the surgeries after receiving chemotherapy and radiotherapy. And in those situations, we have to wait for certain times, and usually it is 4 to 6 weeks. So on one side, we are looking for the optimization of these patients. On the other side, we have to wait for the patients to get optimized because of the effect of chemotherapy and radiotherapy. Now, the goals of management with regards to recent advances is purely based on the patient-centered care. So what we need to require is a preoperative optimization with regards to behavioral, physiologic, hematologic, nutrition. These are the major concerns, and which the recent advances are working on these areas, that which will be the best modality for prehabilitating these patients with regards to optimization. The recent research is also looking onto the data-driven for these aspects of the optimization. Also, with the onset of various regional blocks, including the facial pain blocks, we are still looking for the satisfactory analgesia. I'll come a little later, that there are certain concerns of using opiates in these patients, which can immunomodulate their response, and that can increase the chances of recurrence. It also requires to individualize the perioperative care, the faster functional recovery, because each patient will behave differently. A patient undergoing laparoscopic cholecystectomy for a benign disease is not same as a patient going for radical cholecystectomy because of the gallbladder carcinoma, because each patient will have certain different. For benign disease, probably, if you don't consider comorbidity, the surgical procedure is straightforward. But for the malignant surgical procedures, they will have huge differences. These patients also have a lot of issues with the blood, and hence it requires the consideration of the VT prophylaxis. And definitely the most important, our technique should be such that it improves the oncologic outcomes. And what we use nowadays is the return of intended oncologic treatment. If our treatment modalities delays the initiation of post-operative chemotherapy or radiotherapy or combination, it becomes a huge issue. So we have to provide a perioperative care so that these patients return to their normal routine activities soon, and they can receive the intended therapies as soon as possible so that the patient outcome can become better. Now, coming to the first concerns and advances in the anemia. Now, when we talk about the anemia aspect, the problem of anemia is two-pronged. On one hand, we know that anemia leads to poorer outcome. And on the other aspects, we also know that the treatment therapy in the form of chemotherapy and radiotherapy leads to bone marrow suppression, and these are more prone. And we cannot stop blood treatment. And simultaneously, if we try to treat anemia with blood products, they lead to a lot of immunomodulation and increase the risk of sepsis. And there have been ample number of papers which have been submitted for various oncologic procedures that they increases the risk with regards to infection, with regards to poorer outcome, with regards to increased chances of cancer recurrence. And hence it remains an independent predictor. We also are very sure about the increase in the chances of length of hospital stay, the mortality, the pulmonary complications, the renal complications. But the main issue in the oncosurgical procedure is when we talk of anemia and blood transfusion, it causes a lot of inflammatory changes leading to immunosuppression. And this is what is responsible for cancer recurrence. If you don't treat anemia with blood transfusion, again, there is a possibility that these patients have poorer outcome. So this becomes an issue, and these are the recent topics in research also, that what needs to be done so that these patients are hematomically optimized without requiring the perioperative blood transfusion, and the outcome remains good. And this is what when we say the trigger for transfusion practice is kept usually 7 or 8 grams per deciliter in these patients, and there have been technique to reduce the blood loss in the perioperative period. We're also concerned about the cancer recurrence, and opiate is one of them. It has been found that in various studies, those patients which have used morphine as one of the agents for pain management in the perioperative period, probably these patients or these cohort of patients have been reported to have increased chances of cancer recurrence. But on the other sides, if the regional block with local anesthetic agents has been used, they have been found to have some protective effect. Though we do not have a conclusive evidence on these regards, long-term studies are being run, but they have been literature which cause or mentions opiate and cancer recurrence as one of the issues. We also have to think of the selection of the analgesic technique based on intravenous analgesia technique versus regional blocks opiate-based versus regional block local anesthetic-based. And this has also given a separate arena of research where we are looking for the benefits of the regional anesthesia, just not from pain point of view, but we are also looking for whether it also leads to decrease in the cancer recurrence. We have also shifted from considering the aspects of total intravenous anesthesia versus the inhalation anesthesia. Again, there is some directionality that inhalation anesthesia may be an indicator for immune modulation, immune suppression, and possibility of cancer recurrence. And on the other hand, the TIVA is a protective effect. Though we are not very sure about it, we need a large data to confirm it, but the directionality is there. So this means there are many factors which control the selection of a drug or the technique in the perioperative period. Till date, we are not very sure that whether agents like opiates cause immunosuppression, volatile causes damage to immune functions, but we are still working on a niche area where we can say that probably a technique which is regional based, which is local anesthetic based, which is opiate sparing, and simultaneously, which provides a good pain relief, probably appears to be the acceptable technique for these patients. We're also concerned about the long-term effect. When we talk about the opiates, they not only have direct effect on malignant cells, but they also stimulate angiogenesis and immune suppression. And both these factors are again the risk factors for local recurrence as well as the metastasis. And hence we are looking for a protective technique. And these are all again obtained by use of regional anesthesia and analgesia. But having said that, we are still looking for the large studies, multicentric studies are going on, and we're looking for a broad, big outcome which can confidently say that this is the best technique for perioperative care in patients with cancer surgeries. Simultaneously, it has also been seen the other drugs like NSAIDs, which again has anti-inflammatory action. Yes, we agree that it will lead to decreased amount of pain. It will have opiate sparing effect, but it has also been found that it also decreases the inflammatory response in the body, which also is one of the factors for cancer recurrence. Similarly, not only the local anesthetic being used for regional blocks, but use of lignocaine intravenously has also been found to have suppression on the angiogenesis and other immune effect so that the cancer recurrence is less in these patients. So this means what we need to look for is a safe technique. Yes, it come in time, probably it come up, but as of now, it appears that we have to choose a technique which takes care of the inflammatory status, the neural, endocrine, and metabolic responses are obtained so that the patient outcome in patients with cancer, which leads to a lot of inflammatory changes and immunomodulatory changes, are taken care of. We also need to think of the prehabilitation, which becomes very, very important. Now, it has been very well seen that a patient who has been prehabilitated nicely with regards to various aspects, they have a good immune system and their body to fight the residual tumor cells are very high. So if we can optimize these patients nicely in the preoperative period, the body response by tumor cell phagocytosis is much higher. Some amount of residual cells which are released into the body will be taken care, and hence it becomes essential to optimize them. There has been various aspects of rehabilitation. It needs to be started. And as I mentioned earlier, we have not a prolonged period, but probably 4 to 6 periods. And hence, it's something like training for marathon in the preoperative care. And if we can just optimize these patients, try to optimize from anemia aspect, nutritional aspect, the patient's efforts, the respiratory care, all those things, they can cooperate. The body physiology can cooperate and tolerate the insult during the surgical procedure, and hence they can have good outcome. Simultaneously, it continues with the enhanced recovery program, which is again important and something new for onco-anesthesia. And it also requires intense rehabilitation. I'll come a little later. This is what has been seen in oncosurgical procedures as well. And those patients who has been nicely prehabilitated, the functional capacity is much higher. And when I said functional capacity is improved, they recover faster. If they recover faster, they receive the post-operative care in the form of chemotherapy and radiotherapy faster and earlier. And this is what we want in oncosurgical procedures, so that they return to intended oncology treatment, right, is faster in these patients, and the response of the body to the treatment with regards to the cancer-free duration is much higher. And hence, we should be looking for the prehabilitation aspect with regards to the pre-existing medical condition, functional capacity, psychological status. We can use nutritional and various enduring exercise in the preoperative period so that these patients have good functional results. This is how the patients of cancers are prehabilitated. There have been many aspects which has been considered, and this chart very nicely shows that if these are prehabilitated nicely, the quality of cancer care, the outcome of these patients, the quality of recovery, the chances of cancer recurrence, the chances of comorbidities, chances of complications are much lesser in those patients who receives prehabilitation at right time. Coming to the RAS protocols, I know that this is being done for many of the non-oncologic processes also, but there are many things which are very peculiar to the oncosurgical procedures. Say, for example, keeping them on prolonged NG tubes, keeping them on prolonged Foley's catheter drains, the increased chances of postoperative nausea, vomiting, increased chances of thrombosis because they are prothrombotic phase. All cancer patients are prothrombotic phase. These patients have a high amount of surgical resection leading to more pain. So when we talk about the ERAS protocols in the perioperative period, many of these factors are very peculiar for oncosurgical procedures, and hence it becomes very important to identify them. Say, for example, if we keep the catheters for a long period, these immunocompromised patients has a high chance of infection. And if we remove them early, which we do in majority of our patients, the chances of recovery becomes much better. And hence, we have to follow the enhanced post-operative recovery program with regards to many aspects. It leads to decrease in the occurrence of psychiatric issues. It decreases the stress response. We have to follow the goal-directed fluid management. We have to use multimodal opiate-sparing techniques. We have to reduce the blood loss, simultaneously the need of blood transfusion. The cognitive dysfunction is a very recent thing, and it has been seen. We are doing a couple of research also that post-operative cognitive decline is a major issue, especially in the elderly patient. We have to take care of them. These patients have a huge chance of thromboembolism, and because of prothrombotic phase, we have to early mobilize them, providing good analgesia, and simultaneously in high-risk population, pharmacologic therapy in the form of low molecular weight heparin. We want the organ to recover faster, and hence early feeding is desirable so that ALS can be taken care of. So these are all peculiar concerns. More recent things are coming up from these areas, and the outcomes are becoming much better. And hence we are able to take care. The perioperative care, yes, intraoperative is important as an anesthesiologist, but pre and post care with the involvement of anesthesiology is important. That's why whenever these patients are diagnosed, the anesthesiologists are involved into their management from the beginning rather than a day prior for PAC, but we are also involved in prehabilitation and rehabilitation of these patients. And this has been found to improve the quality of care, quality of life of these patients with many oncologic benefits out of it. The immune suppression that I talked about, maybe because of various components of cancer itself or the treatment, and hence becomes very, very important to understand various concerns that can lead to infection. I just mentioned about the involvement of catheters, CVP lines, Follies, IV cannulas, drains, angiotubes. These are the potential source of infection. So not only we want them early removal, but we also want that during the insertion, a strict aseptic precaution needs to be managed because these are the potential source of infection in cancer patients because of their immunocompromised status. Hence, it becomes very, very important to take care of these in the perioperative care so that we can always manage these patients in a very elaborate way. Whether we talk of antibiotics, it has to be cautiously used in the perioperative period, and it has to be culture-based. Since these patients are immunocompromised, they are immunosuppressed, so there is a possibility that they may not mount the classical way of presentation. Similarly, for vasopressors, we have to use these vasopressors at timely moment because, as I just mentioned, the goal-directed fluid treatment therapy is required. But if we give them excessive fluids, there will be a lot of edema in these patients. They may be nutritionally deficit. They may have low albumin level. Their catabolism is much higher. So we have to use a combination of appropriate fluids in combination with vasopressors. These patients need to be started on enteral feeding faster. These patients may have requirement of insulin therapy because they are immunosuppressed. If for any reason they have higher sugars, they will have higher risk of infections. These patients need to be early mobilized, and hence deep sedation or keeping them on prolonged ventilation is not required. In case if ventilation is required, we need to be careful for lung protective ventilation because the chances of VAP is much higher in these patients, and hence we should be cautious. We also need to be very, very cautious in removing the catheters, including urinary catheter, as early as possible. But simultaneously, it is one of the very good surrogate marker for measuring these patients, for managing these patients with regards to the overall renal perfusion or overall physiology of the perfusion in these patients. We also should be very, very clear about the goal-directed therapies or early goal-directed therapies required for these patients. The other important aspect for onco-anesthesiologists, which is important, is the prognostication. Now, sometimes these patients, while they are being operated, it becomes inoperable. The surgery, total surgery is not feasible. So the patient goes into the operator with the tumor and come out with the tumor with an additional insert of surgical manipulation. These patients may be having, say, a large abdominal mass, which still remains inside. These patients may have a lot of pain, and hence the post-operative care in these inoperable patients becomes an issue. Since the patient has not been operated, the patient still have the tumor, patient has not been treated, the prognostication becomes important for these patients. So we have to prognosticate the patients to, at the post-operative period, the family members need to be prognosticated, and hence it becomes very, very essential for onco-anesthesiologists to take this responsibility also. Since the patient is having a tumor, he will have a psychiatric issue, psychological issues, in fact, and hence we should be counseling them in the immediate post-operative period also. Now, there are certain concerns in peculiar type of surgeries. Say, for example, thoracic cancer surgeries. When we operate on them for the thoracic cancer surgeries, we are usually having a lot of issues with regards to the insult to the respiratory system. These patients will be COPD on the background because COPD smoking is one of the important factor for occurrence of recurrent cancers. They will have a lot of respiratory compromise status. They are immunocompromised and higher chances of ARDS. On this background, the fluid management becomes very, very important. If we give less fluid, the organ perfusion deficit happens. If we give more fluid, we said cancer is an inflammatory stage, it is a catabolic stage. There are leaky capillaries, and this fluid seeps out into the tissues, including the lungs, and hence the oxygenation is hampered. If the oxygen is hampered, the physiology change and outcomes becomes an issue. And hence we have to look for a very strategic way of giving the fluid. We have to have a goal-directed therapy, but simultaneously, we cannot do a fluid loading in these patients because of the leaky capillaries. And hence, individualized goal-directed fluid management is the crux for management of these patients for good outcome. So we have to balance between hypovolemia versus hypervolemia on both the aspects, and that's why it has to be individualized. And this individualization is by a combination, as I mentioned earlier, by the proper selection of the fluids, as well as the proper selection of the vasopressors at times, so that perfusion is maintained. We have to be cautious that the fluid positive balance should be less than 20 ml per kg. Crystalloid should not be more than 2 to 3 liters. Urine output should be maintained. Usually, we don't consider third space loss in these patients. And to increase tissue perfusion, it is just not the fluids, but after fluid, appropriate fluid, use of inotropes, vasopressors is also important. Coming to the airway management, especially for the thoracic surgical procedures, including the lung, airways, esophagus, there are many issues with regards to the malpositions of double lumen tube. Because they are operating in the thyroid on the thoracic area, they do a lot of lymph node dissections. There is a lot of traction on the airway, and hence malposition happen in these patients. So though conventionally we are using the standard tubes, but what is required is we have to continuously monitor. And this is why the newer things, newer techniques, newer strategies are important. Like Viva side double lumen tube. Once they are operating around the trachea, there is a possibility that tube gets displaced. We have to look it continuously. And that's why these type of tubes, which has camera, becomes important. Similarly, sometimes there may be a bronchial tumors. Placement of double lumen tube may not be possible. Sometimes they have to operate of either of the lung. And hence, the new blockers like EZ blocker, which has bilobular cuffs, which can be inflated sequentially, is one of the helpful tool for managing such patients. Also, because of the distorted anatomy, because of tumor, sometimes placement of a conventional tube becomes difficult, and hence a flexible tip double lumen tube again is of help in these patients where they have distorted anatomy, because if you put a normal conventional double lumen tube, the chances of injuries are much higher. Sometimes these patients may have lung metastasis after surgeries, airway surgeries. They may be permanently tracheostomized, and hence we need certain tubes through which we can provide one lung ventilation. So we need specific devices which can be inserted through tracheostomy for providing one lung ventilations. At times we have to use hybrid techniques. We can use various techniques like this, in which a double lumen tube or even our supraglottic airway devices can be used for management. And that's why we should be cautious of using hybrid techniques, because single technique may not be sufficient. We can have fiber optic guided DLT placements. We can have use of LMA as an airway conduit and can use it for exchange to the double lumen tube. We can also think of using the laryngeal mask airway itself for blocking one lung in patients with difficult airway. So these recent advances becomes very important in patients of head and neck surgical procedures, especially thoracic surgical procedures, to look for those differences for airway management in difficult cases. We also need to look for use of the different ventilatory strategies. Sometimes these patients may require high frequency ventilation management because we may not be able to secure the airway with conventional ventilation strategy. We can manage them with high frequency ventilation also. At times, even the low flow apneic ventilation is also required in these patients during certain steps of the surgical procedure, especially the airway reconstructions, and hence becomes very, very important. And even with the availability of Thrive, now these tools has become honey tools of the intraoperative management during the airway surgical procedures, and they're really very useful. When we try to manage these patients, we are little concerned, especially the tumors of the thoracic areas, that how the lungs are being ventilated. And this is a newer tool which is called electrical impedance tomography, which gives certain pictures. And we are able to identify that which lung is being ventilated appropriately, which is not. And this becomes very, very important, especially in those procedures where the airway is involved. Coming to the last slide, when we talk about the ICU care, earlier I mentioned about the immunosuppression. But in oncosurgical procedures, we have to look for these aspects also. These patients remain at high risk, and hence we need to look for the major surgeries with a lot of tissue insult, blood loss, hypothermia, the immediate and early complications, sepsis, and late complications. So these can happen in the post-operative period. So all the challenges in the intraoperative period, on one side, we want to return of intended oncology treatment at the earliest so that they can receive radiation therapy and chemotherapy in 4 weeks or so. This can only happen if all these complications, all these major concerns are taken care of. The patient gets mobilized faster, patient gets starting taking orally faster, the patient tissue recovery happens faster, then only these patients can receive their intended treatment at the earliest for cancer surgical procedures. Hence, many advancements which I have discussed earlier needs to be continued in the post-operative care, which is again a part of rehabilitation in these patients. We have to follow all those things in the ICU care, which I mentioned earlier, and becomes an integral part, and many new things has been added up into the care. So to summarize, onco-anesthesiologists can significantly influence perioperative outcomes through the judicious use of various techniques, drugs, adjuvants in the perioperative period, so that these patients not only return to their normal life, but if required, the oncologic treatment in the form of chemotherapy and radiotherapy can be administered them to the earliest, and becomes the responsibility of onco-anesthesiologists to provide that platform so that early recovery and early receival of these treatments are possible. Thank you so much, and we are open for questions. Over to you, sir.
Thank you, sir. This was really an excellent presentation, simplified to understand such a complex and vast topic. Can I have few words and comments from our moderator, Dr. Balaji Assegaonkar, sir?
Yeah, it's a really very nice presentation, sir. And as you rightly mentioned, the scope of anesthesiologist is not only inside the OT, but he must involve in pre-habilitation, means in pre-operative period, as well as in post-operative period. That is very important. And this is the basic idea of keeping this type of recent advances. Means we as an anesthesiologist should not restrict ourselves only to the OT. Rather, we should actively involve in pre-op evaluation, rehabilitation, and we extend our care of not only pain management, but early recovery after surgery, ICU care. And in this way, we can not only increase our scope, but also we can give a good perioperative services to the patient. And that's you really mentioned very well. I really appreciate your talk, sir. Thank you very much.
Thank you, sir. Thank you so much, sir.
Any questions in the chat box? I think there are no questions because you have elaborated the topic so well. Sir, I just wanted to ask few. In your setup, how do you have the prehab OPD or prehab separate center? So how you proceed with that rehabilitation?
So what we do is we don't have a separate center, though in the newer center, which is 720 bedded hospital, we are trying to have the prehab center separately, but we have a good integrated team. So moment the patient is diagnosed with cancer and is being planned for surgeries, because it will take around 3 to 4 weeks for workup, the histopathological report to come, and the final surgical procedure. So they are sent to us in the PAC clinic, which runs every day in morning, evening, both the shifts. And from there on, we start the prehabilitation, which includes the nutritional aspect, the recovery of anemia, the pain management, the physical exercises, physical therapies, and if there is any comorbidities, we try to optimize it. So this means the patient is not coming, say, a few days just before surgery for just PAC. He comes few weeks before, which includes not only PAC and assessment, but it also requires optimization and prehabilitation. So we have a team of dietitian, we have a team of physiotherapists, and we ourselves try to motivate these patients from other aspects.
So, but thinking about the patient's angle, how patient cooperate with this sort of setup, because already they are wandering from one door to another door, like CT, MRI, chemotherapy, radiations, and n number of consultations with other comorbidities. So they really come to the rehab center or PAC, and how is the patient response towards your workup?
So we have the oncology separate building, so everything is under the same roof. So our OPDs are near to each other: medical oncologists, radiation oncologists, surgical oncologists, onco-anesthesiologists, palliative medicine, physiotherapists, all are on the same floor. So patients don't have to move around, and that's why our services are continuing every day, both in morning and evening sessions. So wherever the patient goes, even if it's for surgical oncologist, he can visit us. And secondly, we do have tumor boards, wherein all the 4 specialties sit together and they take a combined decision. So that's why patient don't have to turn to each specialty separately. So those tumor boards are important, where the radiation oncologist, surgical oncologist, medical oncologist, and onco-anesthesiologist sit together for each patient, and they make a plan. So plan is then made, and then they follow up in the respective OPDs and wards, which runs both shifts, morning and evening, every day, and which is taken care by faculty and residents. So that's why patients don't have to run too much, but yes, a little bit, but they are comfortable with, and they are counseled from the beginning itself, and they do understand, they do cooperate. I fully understand there are a lot of psychological issues and stress among the patient, but we do take care of those aspects also.
Thank you, sir.
Sir,
Regarding yes, sir, please. Yes, ma'am. Anita, ma'am, please.
Yes, sir, congratulations for an excellent, very comprehensive talk on, because onco-anesthesia is something very, very complex, and you just finished. I couldn't believe you finished it so fast. I would have really liked you to elaborate more on one slide of yours where you have, given all the intraoperative management principles, in which you say that the vasopressors we should choose, for example, vasopressor you should choose norepinephrine and epinephrine, not use phenylephrine. So what is the reason, sir? I couldn't get that.
So the reason is very clear, ma'am. I think so today the time was less, 45 minutes, so I try to reduce the various aspects. But yes, my point is clear. The cancer surgical procedures always remains pro-inflammatory. So they are leaky capillaries. Usually the first point of management for fluid management, when we talk of goal-directed fluid therapy, if you're looking for cardiac output monitors or pulse wave contour analysis, we give fluids to achieve stroke volume variation of say 10-15%. But if we give too much of these bolus fluids, because of the presence of leaky capillaries, they will not remain inside the vascular space. They will go out into the third spaces and will cause a lot of edema. This edema is not good for lungs because we'll not be able to ventilate nicely. This edema is also not good for surgeons, because if there's a tissue edema, the outcome there will be a tissue dehiscence. They could be leak into their. That's why we don't want to give them bolus dosages. On the second aspect, we should also consider when we give any anesthetic agent, there will be some amount of vasodilatation. And that's why this vasodilatation needs to be not to be replaced solely by fluid, but we try to give them some vasopressors. And that's why the use of combination of fluid and these type of drugs is important. And as we give them fluid, so rather than giving a bolus fluids of 1 liter or 2 liters, we give them a continuous fluid, and that time is by using other agents, pharmacological agents, so that we are able to maintain the perfusion. So we start these patients on noradrenaline or phenylephrine as per the patient's requirement. The dose should not be very high, because again, it will lead to lack of tissue perfusion. So we need to have a balance of using combination of these two strategies, and there are sufficient research in the recent years with regards to this.
Yeah, thank you, sir.
Sir, I wanted to just rather ask you, now
Yes, sir.
sonography machine is coming in a big help for anesthesiologists, and especially in onco-anesthesia, right, from airway assessment to lung ultrasound to even if patient goes in shock, cardiac assessment, and even so many things that we come giving regional blocks. How do you think in recent advances sonography machine will must be needed for all onco-anesthesiologists in the theater?
I think it will be like an doctor's stethoscope. So I think there is no confusion. As everybody should have steth once they enter the MBBS, I think it's like a bigger stethoscope for all the anesthesiologists, especially who are working in high-risk areas. And you very rightly mentioned, sir, that this tool is being used at all stages of perioperative management, starting off from the preoperative assessment. We have seen, as I was just mentioning, that these patients are prothrombotic. They would have received the PICC line earlier. And we have diagnosed many patients during the pre-op assessment itself when they come to the OT with IJV thrombosis, with subclavian thrombosis. Think if we have not diagnosed it and we have put up a CVP line, there would be probably the chances of tumor migration or the thrombotic nodule migration. Similarly, for the regional blocks, if these patients may be having some amount of coagulopathy, the platelet functions may be low. If you do a blind blocks, the chances of bleeding may be high. On the other hand, we also want a good block because we cannot give a lot of OPS to these patients. The facial plane blocks, which again, if ultrasound guided, have a higher success rate. Similarly, with regards to the hemodynamics, we are regularly using in the post-operative period. As I rightly mentioned, we cannot give them a lot of fluids as a bolus dosages for these patients. So we have to look for how the patient is responsive. Is the patient really fluid deficit? We are using those things from the IVCs, from the echocardiography, from the carotids, so that we can understand them. So I think ultrasound is the integral part of the perioperative care to these patients. And more recently, even though I have not touched today, there's something called frailty. So when we talk about the surgical patients, as we talk about the low albumin level, we talk about anemia, it has been found that those patients who are low in the frailty index have a poorer outcome. And a lot of tools of frailty also includes the measurement of the various diameters using the ultrasound, including the sarcopenias and so on and so forth. So I think this is a very, very important tool required throughout the perioperative care of cancer patients.
Thank you, sir.
Sir, one more question. If the patient, these onco patients are mostly having bone marrow suppression, they are anemic. And if this patient come for non-onco surgery, non-malignant surgery, so how do we really need to optimize them if they are posted for a major surgery?
Absolutely. If you think it's a non-onco surgical procedures, we have to follow the same norms. So we are not in a hurry. So these patients, when they receive the various therapies, they can be optimized. But remember, when they come for non-oncology surgical procedures, like for example, say chemotherapy, it will be a series of cycles, maybe 6 cycles, 9 cycles. So how much you can postpone? Because if you try to optimize, if you give is a monthly cycle, if you give chemotherapy, at the end of 4 weeks, there will be a chances of recovery. But after 4 weeks, again, they will receive chemotherapy. So this means we have to accept and change our threshold because we will never get and fully optimize patients. And that's why the perioperative management, even for non-malignant surgeries in a patient with active cancer, will have different modality, with different management. They will still be immunosuppressed. They will still be catabolic. They'll still be immunomodulated. So even those management will not be equivalent to the benign surgeries. So we have to have some concerns which are still applicable to these patients.
That's great, sir. And what are how about the role of perioperative steroids coverage? Those patients who receive the chemotherapy with adjuvant as a steroid to them?
So those patients who are receiving the steroids as a part of chemotherapy, they need to be supplemented. But usually, once the patient receives chemotherapy, they are usually operated after 4 to 6 weeks. And chemotherapy is a single dose regimen usually for these patients given during the monthly cycles. So when they come to us, usually the effect of the adrenal axis, HP axis is usually recovered. So we don't need to supplement the routine suppressed doses for these patients.
That's it. One last question, sir. You said about something about TIVA and inhalation versus inhalation agent for the thing. Regarding our opioids and better care of the patient. How about the cost cutting by using TIVA in such patients? And we are doing scheme patients under Rajiv Gandhi Yojana and all. So how you tackle this scenario?
I think this is a difficult question because finance is to balance with the way. But I'm not surprised because when these patients receive chemotherapy, which is worth 2 lakh each cycle, 3 lakhs each cycle, I think we should not be worried about few thousand rupees for this. I do understand the financial issues because many of these are under the government schemes, and that's why there's a limitation on the anesthetic agents in the perioperative period. I think we need to work up those people who are working in this policy making of setting up the charges of various perioperative care. They should be little cautious, and they should mention that if this TIVA being used, this should be the charges. If the inhalation is being used, this must be charges. If ultrasound is being used, this must be the charges. I think we need to modify them. But what we are looking for is try to think the other angle. If there is a chances of a local cancer recurrence, the redo surgery is much more costly than using 4 vials of propofol extra, which will cost few thousand rupees, maybe 2,000 rupees. But doing the surgery again will cost lakhs of rupees. So I think we need to have somebody of us among those policymakers. I was in part of some of these Ayushman Bharat schemes. We do try that there should be justification of whatever you use. If you can justify, it should be reimbursed. And that has been done in some of them.
Thank you. Thank you so much, sir. I think we can conclude here because one more faculty is waiting and we are eager to hear madam as well. Thank you so much, sir.
Thank you, ma'am. And I'll be eager to listen to madam also for an interesting topic.
Sure.
Sir, can I ask one thing? Sir,
Yes,
can
sir.
I ask you one question?
Yes, madam. Madam.
Yes. Sir, to add to this, madam's question was regarding infusion of propofol and TIVA technique. So if we add, say, xylocaine infusion, xylocard infusion to the TIVA technique, will the dose of propofol come down?
Absolutely. So we have done a couple of studies at our center also. The giving them the xylocard infusion has multiple effects. One, it decreases the inflammation. Second, it decreases the requirement of the inhalation agent or propofol. Thirdly, it also decreases the requirement of opiates. So all the 3 agents has been reduced. And when I was talking about the inflammatory and immunomodulatory response of the cancer and cancer surgeries, this has also been obtained by xylocard. So there are multiple benefits, and people have started using it. Even the IV xylocard infusion, it should be preservative free. That's only the requirement. It can be used as intravenous infusions in the perioperative period.
Even magnesium is the cheapest drug. We can use magnesium with xylocard as in a infusion. So that will also enhance this will also reduce the cost.
Opiate requirement is decreased. We can use always say 1 shot of magnesium sulfate also.
Yes. Thank you, sir.
Thank you, sir. Thank you.
This was a really great insight. Over to you, Rajesh, sir.
Very nice lecture. Very vast topic, sir. You have covered within a short time. Now we'll switch over to the next lecture. I would like to request Dr. Parna ma'am to introduce Dr. Meghna Nadkarni madam.
Thank you, Rajesh sir. After this excellent lecture, I'm actually speechless. It was a superb lecture, sir. Very nice, very insightful, and lots of take-homes. Thank you, sir. Now I welcome Dr. Meghna Nadkarni, who's been working as onco-anesthesiologist since last 20 years and is currently affiliated with Asian Cancer Institute, Kamala Hill Hospital. She received gold medal in FCPS exam. She got first prize in the case presentation in the lecture at the conference at Latur, which was MSc ISA conference. She is a co-author of the chapter on anesthesia for laser surgery of airway management of the book Treatise of Clinical Anesthesia. Dr. Meghna is also a member of SOPAC Guidelines Task Force. She is in the editorial board member of Journal of onco-anesthesia and perioperative medicine, and she's given many lectures and presentations in conferences and workshops as a faculty. Welcome, Dr. Meghna Nadkarni.
Thank you, Parna, and good evening to
Thank you.
everyone. Rajesh, Parna, Anita ma'am, Balaji sir. After such a great lecture from an illustrious member of our Anesthesia Society, Dr. Rakesh, we move on to a lesser known topic, that is anesthesia for patients who come to us post-radiotherapy. Just a few minutes till I share my screen. So today we are discussing anesthesia and post-radiotherapy patients. This is not a very well-known topic or a very well-researched topic. So I'll be discussing about this in short. Now, we all know that the overall increase in the cancer rates, because we are seeing so many patients now, it has been projected to reach almost 26 million new cases in 2030. And about 30 to 50% of these patients require radiotherapy, either alone as a part of the treatment or together with chemo, surgery, either as a part of treatment or palliation or as a neoadjuvant therapy. Around 7 million patients will receive radiotherapy worldwide every single year. Now, why are we discussing this topic? You have to understand that as opposed to the treatment of cancer, which was done 20 years ago, we are seeing a lot of change. We are seeing newer modalities of treatment. For example, oral malignancies. Initially, when I was working as a student, all oral malignancies of patients of CA cervix were treated with surgery. It is not so today, or even CA esophagus. Today, you will have most patients who will receive chemotherapy or radiotherapy beforehand, before surgery, or CA cervix who comes with radiation or treated only with radiation first. Therefore, you will find many patients who have taken radiotherapy as a part of neoadjuvant protocols, that is before surgery, to either shrink the tumor or give better outcomes to the patient. Patients will receive radiotherapy post-surgery together with chemotherapy or as a palliation because nothing else can be done. Hence, definitely in the future, we are going to see an increase in the patients who have undergone radiotherapy. Therefore, we have to be very, very aware of the side effects and the consequences and the implications that we have to know and be aware as an anesthetist. Now, radiation initially in the olden days was just external beam radiation, which used to target not just the tumor cells, but had a horrible effect and various side effects on the other parts of the body as well. Today, with newer methodology like image-modified, image-guided radiotherapy, proton beam, or stereotactic methods, the side effects are much lesser compared to the previous radiotherapies, but it's not that we are totally free of side effects. Newer and newer methods and technology improves, hopefully we'll see lesser side effects. Now, mechanism of action usually of all these consequences, and even radiotherapy in general, it targets to generate free radicals and damages the cellular components, breaks down the double-stranded DNA and causes chromosomal aberrations in the cells. Now, this affects the tumor cells as well as the normal cells. Repair of the normal cells may be delayed, leading to delayed recovery of the tissues and the patient, or it may not be possible at all. Now, consequences. You may see acute or early changes of radiotherapy that is seen within 3 months. This is usually due to the disruption of the endothelial lining, affecting the various venous and lymphatic systems. And this leads to interstitial edema of the tissues. Like post-radiotherapy, you will see progressive thickening of the skin, platysma muscle, mucosal edema of the pharyngeal laryngeal walls, involvement of the glands like the parotid, submandibular, even the thyroid. Now, the most common effect of radiotherapy that you see immediately earlier after this is the problem with the endothelial lining. So you'll have gastrointestinal lining where the patient will get diarrhea. So you may get a patient who is dehydrated with electrolyte imbalance. You will get edema of the soft tissues of the mouth. So you may have a difficulty in ventilation or difficulty in intubating a patient. Then there is something called acute and chronic change that is seen after the radiotherapy after 3 months, leading to fibrosis and atrophy, salivary glands and thyroid. Now, salivary glands, you will see xerostomia, where the patient's mouth is very, very dry, and he may have a thick, ropey saliva, difficult to do suction and comes in the way of your intubation. Now, thyroid, usually if the radiation field involves thyroid, you may get a patient with hypothyroidism, or later on total thyroid atrophy, or even sometimes if the patient has received radiation to the thyroid, a normal thyroid, I'm not talking of in a case of thyroid malignancy, you may see a PET uptake on the thyroid. Now, late changes are very rare, but there are radiation-induced secondary neoplasms. Now, these are meningiomas or thyroid malignancies. You have to understand that these neoplasms are different from the primary malignancy that the patient has come to you for. These malignancies will have a different histology. They'll be at a site that is different from the primary neoplasm, and they usually have a latency period of more than 5 years. Now, these are some of the changes that you see immediately, early changes after the patient has received radiotherapy. Mucositis. Mucositis can be simple redness, soreness, erythema, to plaque formation, ulcers. Now, acute skin reactions, where the patient gets severe inflammation of the skin. And as you can see, this resolves on its own in about 6 weeks, but can hamper us in a way. Now, osteoradionecrosis. This is the most dreaded complication and devastating complication following radiotherapy, where the bone is devitalized and this is being irradiated and it's exposed. The overlying skin or the mucosa is totally gone. And this is something that persists for more than 6 months and seen after 6 months of getting radiotherapy. Mostly seen in the mandible because the mandible is a highly vascular bone. Now, the pathology here is mainly the hypovolemia and, the less blood supply to the mandible because of the radiation, leading to hypoxia of the cells, cell death, and tissue necrosis. Now, the treatment modalities for osteonecrosis, a patient may come to you for the treatment, can be from simple sequestrectomy to debridements to teeth removal, or in severe cases, the only treatment that is known to really take care of this is segmental mandibulectomy and reconstruction with free radial flaps. This is another case of osteonecrosis, which is infected. Now, if you see the airway changes, this slide clearly tells you all the things that are affected and the anesthetic implications. So you have necrositis, mucositis, face, buccal mucosa, ulcerations, fistulas, urine and discharges. So you'll have difficult mask holding. You may have a little bleeding. TM joint, again, trismus. So you'll have fibrosis. Because of fibrosis, so 100% difficult laryngoscopy. Tongue, glossitis or edema. So difficult laryngoscopy, maybe bleeding and difficult to assess the airway. Dentition, again, difficulty in mask holding. Flora of mouth fibrosis definitely affects the mobility of the tongue. So even if you have a patient who says, my mouth opening is good, but if the tongue protrusion is not there, you can definitely expect a difficult laryngoscopy and intubation. The mandible, we have seen osteonecrosis and pathological fractures. Suprahyoid region fibrosis and edema, so limitation of flexion of the occipital joint. And lower airway edema, so patient may come with snoring, hoarseness of voice, irritant cough, so difficult visualization of the larynx and difficult intubation. Now, if we come to one of the dreaded complication of radiotherapy, that is radiation-induced liver disease. It's typically seen 4 to 8 weeks after completion of radiotherapy. Two types, classical, which is seen in patients who do not have any underlying liver disease. So your patient will come to you with fatigue, abdominal pain, hepatomegaly, ascites. And classically in these patients, the increase in the alkaline phosphatase is out of proportion to the increase of the other enzymes, bilirubin or ammonia. And diagnosis is a diagnosis of exclusion after you have removed all the other factors causing liver disease. And if you see the non-classical type is a type in which the patient already has a liver disease. So he's going to come to you with jaundice and an increase in the transaminase levels as well. Now, this is radiation-induced lung injury. Any lung toxicity induced by radiation is known as a radiation-induced lung injury. So here you have 3 phases. Early phase is the pulmonary edema because it affects the lining of the cells. So you'll have an increase in the capillary permeability, loss of surfactant, transduration of proteins, and to the alveoli and a pulmonary edema. Seen early on in the disease, within 2 to 4 weeks. In the intermediate phase, within 6 months of therapy, mostly within the first 12 weeks, you will have a pneumonitis. So a pneumonitis is something that is seen because of damage to the pneumocytes caused by the radiotherapy. It is an ongoing process seen from the early phase, not resolved, leading to an intermediate phase because of the immunomodulation and damage to the pneumocytes and cytokine release. Then if this stage is also not resolved and progresses later on, you get the late phase, which is probably anywhere from 6 months to a year, which leads to pulmonary fibrosis. So as you can see in the first picture, you have a patient, the arrow pointing to the left upper lobe tumor. It has a chemopotent place, so probably taking radiotherapy, and a sort of a ground glass attenuation on the X-ray, which is classical of pneumonitis. Whereas in the other X-ray, you will see a classical whitish thing, a whitish shadow on the X-ray. You can see the pull of the trachea to the right, which shows a pulmonary fibrosis. Now, cardiotoxicity. Cardiotoxicity because of radiation is usually seen because of radiation to the breast cases, radiation to the mediastinal, radiation to the lung cases. So, and it has a whole array of diseases affecting right from coronary heart disease to valvular heart disease, where they say that the mitral valve is most involved because of the way the radiation given, so left side is affected more. You may have conduction abnormalities and cardiomyopathies. All this is a result of endothelial damage. Now, vascular injury also is known to be seen with radiotherapy. It accelerates atherosclerosis, and as Sir said, it's a prothrombotic phenomenon. Cancer as per is prothrombotic, plus radiotherapy also. So can lead to acceleration of atherosclerosis. Sometimes in very rare cases, it causes direct injury to vessels. We have known patients of coming to the emergency setup with carotid blowouts following radiotherapy. Now, if you see the assessment, airway assessment is very, very important. You have to understand that you always have to have expertise to handle the air. Various gadgets, tools ready to secure the airway, as in any difficult airway protocol. A well thought of plan to secure the airway, a backup plan, and maybe, of course, front of the neck access always available. Now, if you see the pre-op evaluation, detailed history as regards the treatment taken previously, any medications, allergies, any comorbidities, any other treatment modalities already going on, chemotherapy, now immunotherapies come up in a big way, any recent changes in the severity of symptoms, and appropriate investigations that are tailored with respect to his various comorbidities, the type of surgery, the duration, and the complexity of surgeries. Now, Sir has touched upon this topic really well. So I am not going to go into detail in this, but we all know that the outcome should be such that it improves the patient's functional status before surgery, enhances recovery by decreasing the complications and the length of stay in the hospital. Each patient has to have an individualized approach for this with regards to nutrition, psychological support, exercises and breathing exercises. So he knows basically his condition is improved and what to expect post-surgery. Intraoperative strategies, again, since they are major surgeries, you are expecting extensive blood loss, you will do invasive monitoring, temperature regulation, lung protective ventilation, and balanced fluid management. The conclusion is that each patient is different. There has to be a team approach, a patient-specific approach. You have to treat the patient as a whole. Here we spoke of only radiotherapy, but you have to understand that the patient is going to come to you who has taken chemo, who probably has some other medicines going on, taken radiotherapy, maybe 1 or 2 cancer surgeries have already taken place. He's come to you for a recurrence. He may be having an underlying COPD or some changes in the lung because of COVID. So you have to be aware of all this, and you will only be aware if you know what to look for. There may be a few surprises when you do intubation or something. So you have to be always present, vigilant, and presence of mind is needed. And your backup plans have to be ready. Thank you. I would love to have some feedback from Dr. Rakesh and his team members and whoever's sitting there.
Thank you so much, Dr. Meghna. And thank you so much for accepting the invitation. She's traveling, and in spite of that, she accepted the invitation. So thank you. Thank you. It was a wonderful lecture. And yes, sir. Rakesh, sir. Sure. Feedback from you, sir.
Rakesh, sir.
Probably get disconnected.
First of all, speaking after Rakesh sir,
no, it was a wonderful lecture. Okay, till the time we get.
Yeah, and it's very different when you're working in a private setup where you don't see the patients, you know, weeks before surgery, where you can really optimize them.
That's what I wanted to ask about that pre-habilitation, because patient come to 1 day prior or directly on the table.
Yeah.
So how to optimize that patient? Yeah.
You can't. Or if the surgeon is
you just cannot reject them. Whatever is the condition, either bone marrow suppression, septic, or whatever, you have to accept the case.
I think you have to just
absolutely,
you know, change your methods and the way you handle cases so that patient outcome is the best what you can give in your setup.
Perioperative coverage can be given from our side, like optimizing the patient, and even in the post-op, even in the ICU, we can take the follow-up. But beforehand, patient won't come to us so weak or
At the most, what you can do pre-op is probably if you feel he's dehydrated, oral malignancies, not having, intake is very poor. You can shift them to ICU, put in a central line, and, or start albumin, or, give fluids to optimize the fluid status beforehand, electrolyte imbalance.
Yes.
That's all you can.
Balaji sir, your insight?
Yes, very good talk, madam. Only I also face the same problem. Means the person who is had a neck radiation, and when he obviously it was not a very difficult induration, and suddenly you get a surprises that maybe due to induration and all anatomy has changed. So many times we face. One point you mentioned about his protruding his tongue can be a signify that.
Yeah.
Is there any other clinical methods or clinical sign or symptoms by which you can predict that these patients can have a difficult intubation?
See, sir, anyways, you will follow all the signs that you will anyway assess the patient for a difficult airway, which we normally do. Here, you only have to remember that the neck may be irradiated. So, it's very difficult to hold the mask. And this is where ultrasound really helps because you cannot identify any structures in front of the neck. It is totally hard. You will not be able to identify any hyoid, cricothyroid membrane, nothing.
Yes.
So this
Even
is
in that case, identifying epiglottis was not possible. It was twisted,
yes,
and it was really very difficult scenario when you face such things.
Even, sir, there is a cord edema post radiation. If you
Yes.
get the patient within 4
and
weeks,
it does
so there is
not
extreme
go.
cord edema. There is absolutely a chink-like opening. And if we have not predicted this as a difficult airway and we give propofol and everything, these patients turn out to be a difficult ventilation as well. So predicting and doing preemptive fiber optic is a good choice.
Yes, or otherwise also, rather than just give sedation, do laryngoscopy.
Yes,
See
yes.
if the things are getting
Also,
visualized, then
see, video laryngoscope also has changed the game, but it's not available.
yes,
Yeah.
yes.
If the tongue protrusion is restricted, then probably the mouth opening is also restricted, and video
Not
laryngoscopy.
necessary, not necessary.
Not necessary. Many times there is
many-
no any obvious
sign.
means criteria of difficult intubation, and suddenly you'll end up with difficult intubation.
And this you'll probably see in patients who don't require much of a, CA tongues, who just come for wide excision or
Yes.
not a hemiglossectomy, little less than that, and the surgeon sutures the tongue to the floor of the mouth.
Yes.
And sometimes
This is about the yes, ma'am, please.
Sometimes this funneling in the pharynx is because of the effect of tobacco which the patient is taking from beforehand. So even if there is no radiation and the patient is of you think that it's a minor tongue, just maybe a minor excision of the CA tongue and just the local suturing there, only local flaps. But they can turn out to be very difficult if there is a funneling inside and that effect of tobacco is there, which is like radiation only. It will just contract everything. No movement, rubbery base of tongue will be there. So there'll be no movement of the pharyngeal structures. You externally also you can't manipulate the larynx because it's become very hard.
Patient Few patient I came across that post radiation, even the to give the transtracheal injection of local anesthesia, you cannot find the trachea. So USG guided, you can locate the trachea and put it in the cricothyroid the thing. So that is also a very useful technique.
Oh, and see, to do these things in an emergency setting,
no,
unless you practice them before.
Yeah.
Yes.
See, a word of caution, even USG doesn't look the same like in a normal patient because the structures are pulled and even the texture of the skin subcute, it's all tethered to each other. So you won't see, unless you see 100 patients airway, 100 normal patients airway under USG, you will not know where is what. So for a fauna, if you are looking at this patient's airway in emergency, you will not know head or tail of it. You need to really do a practice on normal patients.
So if you have an ultrasound in your OT, we should have to screen every airway before intubation.
Parna, you should ask Dr. Vijaya Patil to give a lecture on ultrasound in the airway. She gives a very good lecture.
Okay, I'll do that. And in fact, front of the neck access also would be very difficult in these patients. And also, I wanted to ask you one question that because of the radiation of the neck, also the thyroid gets involved.
Yes.
So, So Dr. Garg was talking about these patients cannot be optimized very well pre-operatively, and all of us talked about it. So what is the TSH level that you will accept in these patients? Because many of these patients would be hypothyroid, subclinically.
See, most of them are asymptomatic.
Yes.
Most of them. But what you need to understand is you cannot go beyond that 4 to 6 weeks window to do the surgery after finishing radiotherapy chemo, because that is an optimized time for surgery for the best outcome for the patient. So the patients are usually counseled, patients are started on treatment, and it's good that you see a decreasing trend.
Okay.
Continue the medications.
Okay. I read an article in which it said that that institute, they were accepting TSH levels of about 15,
15,
you know,
yeah,
in
right.
these patients.
Yeah.
Yeah. And also, even if they are subclinical hypothyroid patients, they were starting the patients on Eltroxin.
Yes.
And that, yes. So that improved
Because
the
the thing is,
outcomes.
it's only going to progress.
Yes.
It's affected by
Yes.
radiation. So
Yes.
he's anyways going to need the medicine anyways.
Yeah.
Madam,
So
as
I
you
think
said,
this point, if you allow, can I add, Dr. Parna?
Yes, sir. Yes, sir. We were waiting for you actually for your feedback and for your inputs.
I was learning from you. It was a nice discussion. With regards to the optimization, this is applicable for all disease, whether it's diabetic, thyroid, hypertensive, or any other disease. Though we do not have the time for complete normality, but we should initiate the treatment. And so that whatever is optimized is fine. And with regards to the hypothyroid, yes, we do that TSH of 7, 8, 9, 10 are usually seen in these patients. And usually we do not postpone these patients. But we need to look for the clinical symptomatology. So as Madam said, usually they are clinically asymptomatic. But then additionally, we also need to think of when we were looking for, say, TSH of 5 and 6, those were the eras where we were using the long-acting agents like pancuronium or morphine. But nowadays, we are using agents which are shorter acting. Say sevoflurane, desflurane, fentanyl, now remifentanil will also be available. So when we talk about the drug metabolism, it's not a major issue. So we have to just modify our technique a little bit. Maybe we can use neuromuscular monitors for a faster recovery. But the management, they should not be postponed for a long time.
Yes,
with regard to the second discussion, which you were discussing about, I understand in the private sector, the patient will be coming a day or two prior to you. But I think in oncology, it's a team approach. I'll just let you, if you can just incorporate or make your surgeons understand, because surgeons also wants a good outcome. They also want to take a loyal. I remember years back, one patient came to surgeon for thanking him. And he said, see, what a nice surgery I have done. It was a painless surgery. I was just standing behind him. I said, surgery was painful, sir, but it was anesthesiologist who make it painless. So surgeon also wants that their outcome should be good. So if we can just discuss with them, there are various modalities. Like one of my surgeons, what he has done is, he has just make a stamp where he returned 45 minutes of walk every day, high protein diet, deep breathing exercises. And so he has made 5 points and he just steps for the OPD card. I think that's just good enough to initiate the prehabilitation. So even if we do not tell, putting that stamp, I'm so happy that when the patient comes to me, even 1 week, he gets double endorsement of rehabilitation. So I think in setup with private sector, I can just suggest, why not to have a small infographics or a small flyer that can be given to these patients of the perioperative care. Just ask them 30 minutes of walk, high protein diet, deep breathing exercises, just mention it. And it will be absolutely wonderful. I've just completed one research in which I have made a small booklet of 10 pages. That was a part of a research project. And I give it to patients the moment they are registered with us. And there are certain things which I just discussed and mentioned into this with photographs. So even if they do it 20%, 30%, 40% of their own, I think there is some benefit. So we can have the strategy in the private sector also, because I think surgeons will be more than happy if their patients are discharged on 3rd day without complications, because they're also looking good for their patients. So these are small suggestions where we have time limitations. We can include these type of modalities to improve our patient outcome. And we need to have good rapport with the surgeons, with the team actually. And if I say something to surgeon, don't do it, they don't do it. I said, do it, they do it. Sometimes I force them to do the surgery. I don't want to postpone it. So I think this way, this type of combined team effort which is very essential. I think this is equally applicable for government or private sector both.
Absolutely right. Absolutely right. Thank you. Thank you. And you must show us that booklet. You should share it with us. Yes, sir.
Share that booklet because
I will share. That is part of IRAS protocol, prehabilitation, I'll share.
Okay,
And
thank you,
Thank you, sir. It was a wonderful
Yes, that sir has said that. I mean, let us go ahead and rather than saying that okay, we can't see the patient pre-op and what can we do, but there is always a way ahead. So really, that is such a great suggestion, sir, to have a booklet and just to keep sharing that booklet with every patient so that knowledge is given to the patients. And whatever, I mean, even if they follow some part of it, it will be useful. Yes. Thank you, sir.
And also explaining the patient, like somewhere I read that undergoing a major surgery is like running a marathon. So while we are giving the booklet, if we also explain to the patient that you need to take adequate proteins because you have to get set for the surgery. So I think the patients nowadays, they are very intelligent and they generally follow whatever we tell them. So I think it will have a very good impact on the patients and they will also optimize themselves. So, yes. Thank you, sir.
Thank you.
Rakesh sir, may I ask one question? Last one.
Yes.
I think, sir. Madam, do you give gabapentin to for the patient who are having pain preoperatively 1 day prior? Those patients who are you are anesthetizing the next day?
No, honestly, in our setup, we don't do that.
Okay.
But it can be done. I know many people who do it.
Okay.
Yes, actually, it is a good. It's a part of ERAS. I mean, gabapentin given to most of the patients you can give, and it really helps in multimodal analgesia.
Yeah.
Good quality of sleep. Even they are giving now melatonin. Instead of giving benzodiazepines, they give melatonin on the previous night for good sleep. So many changes.
What is the dose of that, ma'am?
Melatonin, you can give in 5 milligrams or 10 milligrams. It's a part of ERAS protocol to prevent the cognitive dysfunctions, especially geriatric patients. They can react to, they have cognitive dysfunctions with the benzodiazepines like Alprax. So they use melatonin. And melatonin you can use in all patients. I mean, it's really, must be aware, Meghna, of melatonin.
Thank you, ma'am.
Thank you. Rajesh?
Yes. Very good lecture series from onco-anesthesia by Dr. Rakesh Garg sir and Meghna Nadkarni madam. First of all, I'm very thankful to Dr. Rakesh Garg sir. He elaborated the vast topic in a very short time, very nicely. I'm also thankful to Dr. Meghna Nadkarni madam. She has accepted our request for the lecture in a short time at the 11th hour, and she is leaving for the US next week. Even though she has managed it very well, I'm very much thankful. Special thanks to Dr. Sujata Jini ma'am, who is always ready to help us even told at the 11th hour. I am thankful to Dr. Vikas Karne, who is always attentive and helpful even with his busy schedule. Thankful to Dr. Sachin and Dr. Parna. Special thanks to Dr. Balaji Asegokar and Anita Nethe ma'am for question and answer and moderating the webinar. And lastly, the audience who is very important in the webinar series. I'm very much thankful to respected IS members as audience. Thank you very much.
Thank you. Thank you.
Thank you.
Thank you,
Good
sir.
night.
Thank you, sir. It was a wonderful session.
Really, it
Yes.
was very good. It's a
Yes.
very topic and very nicely discussed. Very short presentation by both the speakers. I would have really liked them to go on for some more time. Very good.
We have utilized that time of presentation in discussion.
Really.
Thank you very
Thank you.
much.
Thank you very much.
Okay. Good night.
Thank you. Thank you. Good night.
Bye-bye.
Bye.